All right, crew, welcome back. And today we're going to talk about some blood. Or more importantly, the study of the blood and how it works. The good news is that we've actually gone over a lot of this in A&P, so I'm not going to kill you guys with a lot of it. So we will be kind of going a little bit fast on this one. Because again, I'm not going to dwell on things that we've already learned about, but it is a good review of the blood and how it functions and how it works. And and then we're going to talk about some of the problems with it in the second video involving the hematology. So again, hematology is the study of blood and blood-forming organs. Okay, so anything having to do with the formation of blood, we can do that. And then there's the disorders. We got red blood cell disorders, white blood cells, which is our immune disorders, platelets disorders, being able to stop bleeding or bleed or forming clots when they shouldn't, or coagulation problems. Okay, so again, when we're talking about the hematology, that's what we're talking about it. And some of these diseases are genetic, and again, some of these are actually centralized to an ethnic group. African Americans would be the good example of a sickle cell patient. Again, you don't. I have never heard of a Caucasian person having the ability to actually get sickle cell, but I'm sure that there is a case out there before everybody goes to looking for it. But again, it's very rare to see that at all, if you see it at all. And again, remember that your red blood cells carry oxygen. Okay, they help. They help in everything that we do. It maintains your pH levels, and again, and you really need to be able to take a good history in order to figure these out. But usually, it's going to take laboratory findings to actually confirm what you're going to find out through taking a good history physical. The hemopoietic system contains the blood, the bone marrow, the liver, the spleen, and kidneys. Okay, so again, this is your filtration and again the cellular components. Again, that's where it actually makes the stem cells. This is in the bone marrow. That's where we actually create the blood. That gigantic hemopoiesis actually is talking about red blood cell formation. Okay, and again, they mature into basophils, eosinophils, neutrophils, monocytes, erythrocytes, and thrombocytes. The gigantic words here. These are all four of these here, guys, are having to do with your white blood cells. Erythrocytes are red blood cells. Thrombocytes are your platelets. Okay. So again, your kidneys they're responsible for making red blood cells. So is your liver; it detoxifies it, and then your spleen. Again, these are the cells that scavenge abnormal blood cells and bacteria, and turn it into other products. Again, usually your blood volume is about 6% of your total weight, and again, red blood cell mass and plasma volume is actually what determines it. And if we go a little bit deeper on that, hematocrit, your hematocrit and your hemoglobin. Sorry, I couldn't even think of it. The hemoglobin and hematocrit. Usually, your hemoglobin's about 45% of that volume, and the other parts of the blood are about 50%. And again, usually the only change is the rate of production that can alter the size of the circulating red blood cell mass. Your plasma volume, that changes pretty easily and readily. Think about that. We can dump a liter of normal saline into somebody, and we can change their plasma volume fairly significantly by doing so. Maybe not necessarily a good thing, especially in the case of hemorrhagic shock, when they're losing red blood cells and we're only putting salt water back in. Well, salt water doesn't carry oxygen, okay? But again, if I've got somebody that's been vomiting for 5 days, boy, normal saline is a great and wonderful thing. Okay. Again, when compensatory shock measures fail, the patient enters a decompensated shock. But our mechanisms of compensating again is your tachycardia, especially in children. By the way, again, you vasoconstrict and you increase the squeeze of your heart. Okay, so these are all compensatory mechanisms. But once they fail, you will get profound decompensated shock because of that. Your plasma is a thick, pale yellow fluid. It's mostly water. There's some proteins in there as well. And again, these guys can be transported. They transport waste products to the livers, kidneys, and lungs, where they're removed from the body. And then most components can be back and forth across the capillary membranes. And again, plasma leaks are kind of common. Matter of fact, your lymphatic system that's what its job is to help return that to circulation. Again, there's other plasma proteins. Again, clotting factors. It dismantles clots. Again, it buffers it for acid-base balance, and that's kind of a big one there. And then again, remember your hormones transmit through these. All your endocrine, they dump it into the circulatory system, and it also can provide a source of energy for us. Now again, remember that we do have electrolytes in they're dissolved in there, and that is responsible again for your muscle contraction, your nerve contraction, and maintaining your balances with these. Again, carbohydrates is your energy source, again, and we really want to add that with oxygen, therefore turning into an aerobic thing. And again, we're not going to beat that dead horse. But we will, again, your red blood cells, just remember, these are the guys that actually transport. And remember on a red blood cell, by the way, that there are 4 heme molecules, which is what causes the little dip in here, in this little dip area. Again, it's the polarization effect of the heme molecules, okay? These guys, the greater number of red blood cells is usually the greater potential oxygen carrying capacity. Remember that your oxygen bound to hemoglobin increases the PO2, okay? And again, but that's how much is actually on. Now, your SpO2 is when we're dealing with how much is actually saturated on the cell. PO2 is actually how much oxygen is being carried. So that's the difference between the two measurements, okay? By the way, waste, the Bohr effect. I want to make sure you understand this, that waste carbon dioxide diffuses into the blood and then causes hemoglobin to give up more oxygen, okay? That's called the Bohr effect, and we've talked about that. We've kind of bounced around it a little bit. We're talking about acidity. So again, it does serve a vital function there. So the lower the pH, the more readily the hemoglobin gives off their oxygen, okay? Again, can be a good thing, can also be a bad thing at a certain point, all right? Again, your set for hemoglobin, the most abundant chemical in your red blood cells is 2,3-GPG, and we talked about that. If you remember right, we talked about that when we were talking about the oxygen hemoglobin dissociation curve. This 2,3-GPG is actually it increases those levels and makes it more difficult for oxygen to combine with hemoglobin in the lungs, okay? So that's one of the other bad effects with this. So again, the CO2 helps us keep it and then release it easily, but with this guy right here, it makes it more difficult to actually combine oxygen into this, okay? Now, and by the way, the more of that shift that you get with acidosis, the more 2,3-GPG that you get, that causes that, again, you don't actually saturate the red blood cell, causing more problems, okay? Again, exercise decreases, makes your blood more acidic, and then it causes the body temperature to go up, and that will also help release oxygen into the tissues, okay? Carbon monoxide, by the way, yeah, it loves a red blood cell. It binds 210 to 250 times more affinity to it. In other words, it's going to really grab onto it, hold onto it, which makes that problem with carbon monoxide that we talked about during our toxicology really makes it a lot worse. So again, we talked about these things already, the red blood cell production, and the standard red blood cell lives about 120 days-ish. Okay, so again, what can cause again, hemorrhage can, the destruction of red blood cells, and yeah, all these things can happen. And then the hemorrhage may occur outside the body or be hit within the cavity or in the GI tract. So there's lots of places to lose it. Hemolysis, again, may occur with the circulatory system in sickle cell disease and a rare autoimmune anemia. So basically, it destroys the red blood cells as part of that, okay? And again, they will do that, and then the liver and the spleen start to take away from those. And the good news is that they actually do have a little bit more affinity to take care of the sickle cells, but when they're not functioning correctly, that's when you may get a more prone to a sickle cell crisis, where the the abnormally shaped blood cell actually blocks up the vessel, especially the microvessels. That's where the problem is. Usually, by the way, the red blood cells are reported in the millions per cubic milliliter. So that's, again, you've got a lot of red blood cells in a drop of blood. Okay, but it's very important that you want to hold on to those guys. Okay, the hematocrit again is the packed cell volume of the red blood cell per unit of blood. Okay, which is kind of why we want to know hemoglobin and hematocrit of where those levels are, okay? And it's probably better to show you here. This is kind of more of a what is hematocrit versus, and then the hemoglobin is your actual count down here of these guys. So again, the hematocrit is actually whatever level it is that this produces the plasma. And again, at too low, obviously you're going to have problems. Too high, of course, you're going to have a major problem. And I'll give you a little hint, by the way. If their hematocrit, usually their hemoglobin is level is 1/3 of whatever this number is right here. So the standard number for hemoglobin, by the way, is 15 for females, around 20 for males, by the way, just a little bit higher. But again, it's usually 1/3 of whatever that number is. Okay, and again, we already talked about that. And let's talk about some white blood cells. These guys, again, they go around and they basically protect you from forward invasion. They actually surround usually whatever damaged. They call it it engulfs and destroys it by phagocytosis. And these guys right here, this is an example of a phagocytosis. There's a lot of lysosomes, by the way, in your white blood cells, which help destroy that whatever that organism invader is. Okay, and again, usually healthy people is they say 9,000, but it's probably more like 5 to 10,000. And then above 16,000, that usually means you have some sort of infection going on, and it's usually an increased white blood cell count is usually a really good sign of a bacterial infection. Okay, the problem with the virus is they get in there and they start messing with the actual cell, and so they really don't. The white blood cell counts don't elevate for a viral, or sometimes for a viral, sometimes for a fungal infection they will increase. I'm not going to say always. But again, the leukapheresis is the stem cells that cause these other formations of these guys here. And you don't really need to know. You be able to recognize the term, not necessarily that you know them. Okay, and again, these guys, the granulocytes, by the way, they are the ones. And one of the ways that we tell the way what type of organism it is we stain them, and that's where that granulocyte staining comes in, of where they turn a different color with this particular stain. Okay, and again, not that you really need to know it, but if we start getting into antibiotic therapy, the reason that you need to know this is because if you're trying to use a gram-positive an antibiotic that doesn't work against gram-positives, and that has to do with the shell around the whatever the bacteria is. If you're trying to destroy them by increasing that with a gram-positive, it's not going to work. And the flip-flop is also true. So again, yes, the type of cell membrane around a bacteria or a viral load does make a difference on how we boost the immune system via antibiotics. Okay. Let's see here. Again, the neutrophils are the ones that actually fight the infection. And again, if the neutrophil count is low, again, the body can't mount an appropriate defense. Actually, truth be known, HIV patients, that's how they die. They just don't have a response to the invaders. Again, that destroys their it's essentially natural immunosuppression. Again, they can't fight off the simple infection that normally you and I would fight off with no problems. Macrophages, these are the garbage collectors. They get the dead neutrophils, and then they remove them and then they take them back to either the kidneys, the liver, the spleen, or actually into the GI tract where they dispose of these things. Again, sometimes in the area, if it's a localized infection, yeah, that's what it is. Newsflash, yeah, you're squirting a whole bunch of macrophages out. Okay. Again, the lymphocytes is the primary cells involved in immune response. Again, they're located in the circulating blood and tissue, and they're really small, round, and containing no granules for staining. The thing that activates the immunity, T cells and B cells, and we talk about T cells a lot because The immunodeficiency very specifically attacks the T4 cell. And these guys, and that's what develops the cell mediation or cellular immunity. And then the B cells are the actually ones that combat the infection. They're the ones that signal all the other fills, if you will, to approach and attack. But again, it's the T cells that will activate those guys. All right. And we already talked about this, and we already talked about that. In the inflammatory response, one of the things that happens is when you do have some sort of foreign invader is that the body knows to start pumping blood into that area. Again, a good and a bad thing to that, okay? Or if there's damage to the body, it increases blood flow and fluid flow to that area in order to destroy the invaders and start the repair process. It results in redness, warmth, swelling, usually in pain and usually fever. Okay, so and when this happens really too rapidly, again, that's when you have more of an anaphylactic reaction. Now, your platelets, these guys are the ones that are actually responsible for clot formation. Okay, again, sometimes a good thing. In the case of a heart attack, probably not a good thing. Again, you can have too few platelets, which is known as thrombocytopenia, or you can have too many, thrombocytosis. Again, in both of which, and by the way, too many can cause clots everywhere, okay? Too little means you'll bleed to death, a hemophiliac, okay? And hemophiliac obviously means to hold on to your blood. So that's why, again, when you cut a hemophiliac, they're going to bleed and bleed very freely, takes forever, or they're on blood thinners, vitamin C, warfarin, Coumadin. Oh, that's horrible. They bleed like crazy, okay? So again, your platelets, usually they're about 7 to 10 days. We learned that when we talked about aspirin. Remember that what that does is it actually removes that ability for them to form nets, which is, and again, it's good enough for 7 to 10 days of the cell's life, okay? And then it's usually activated when they contact an injured site. They aggregate and they release chemical messengers that actually activate the clotting system. We talked about the clots back when we were talking about AMP. And again, you get vascular spasms, which initially control the blood clot. They'll get the platelet plugs, and then you start forming a fibrin clot, which is that is your coagulation. Again, you're tougher, if you will. And then when the blood vessel tears, again, the smooth muscles of those vessels contract. We just talked about all this lovely stuff. No need to say it again. Again, the platelets form a plug, so this would be an example of the clot formation. And the big one there is that it forms a fibrin net. Fibrinogen turns into fibrin, and then it catches the red blood cells, and that's what forms your initial clot for these folks, which is why you don't want to move. If you've got direct pressure on there, you want to let that clot form. The longer you leave it there, the longer that clot has to form and become more solid. Okay? Now, hemostasis, again, this is the damage to the blood vessels linings, and again, it can lead to a cascade progression, which again should form a clot when you do that, okay? And then damaged cells, they send out the chemical messages that activates the clotting factors, and those clotting factors is what actually breaks it and forms the fibrin nets, and that's what actually holds on to those red blood cells, okay? And by the way, once bleeding stops, that's usually when your inflammatory process begins. So when you get somebody in a wreck that was bleeding and now they're not bleeding, it doesn't hurt so bad, we get them to the hospital, 30 minutes later, you open up the bandage, and that sucker is twice the size that you initially had. Well, that's why, because again, your body's sending what it needs to start the repair itself, okay? So again, these are common pathways for that to happen, all right? So eventually, it does not mean it doesn't stop the cascade. By the way, by that time, again, it starts to dissolve that clot. But by then, the fibrin has formed, and the scar tissue has formed, and it allows it to be a more permanent solution to that. By the way, so your fibrinolytics are the only effective agents who block the ability to form a fibrin clot. Fibrinolytics are good. Let's say you have a thrombolytic stroke or a thrombolytic heart attack in which you can't actually get to a cath lab in a decent amount of time. They can give fibrinolytics in order, but you got to remember, fibrinolytics don't know your heart arteries from your heart clot from your leg clot. Okay? And when the reason I say it like that is well, they got a big wound on their leg and you hit them with fibrinolytics, well, yep, they're going to start bleeding and they will not stop. Okay? And again, Patients that lack clotting factors, again, there is a way to give them those clotting factors, but again, it's harder to control bleeding if they don't have the clotting factors. They don't have the ability to form those nets. Okay. By the way, good examples of the fibrinolytics is again aspirin, warfarin, cumin, heparin. Okay. So, and if you've seen these drugs, guys, they're gonna be free bleeders. They're gonna bleed a lot more. Okay. Glycoprotein 2 and 3, the only reason I bring that up is because we do a lot of transports with heart cath folks that do integralin. Integralin is a glycoprotein 2B, 3A receptor pathways, okay? And it's used to treat the acute coronary syndrome, and it's usually combined with a stent placement, it can be with or without stent placement. Again, RiaPro and Aggrastat are two other drugs but the biggest one I've ever seen is integralin. Okay, and then these drugs can actually be used to increase clotting using, again, vitamin K, polycythemia cancers, byproducts of tobacco use. They can lead to increased clotting. Okay, sorry, I didn't mean to say that they help you clot faster. This leads to, again, more clotting for these patients. Okay. Again, blood types. Again, these are having to do with the proteins that are actually within the blood. There's an A antigen, a B antigen. If you're lucky, then you were born with both. If you were unlucky, and you're born with neither. Okay. The problem with the antigens is when we're transfusing someone. Okay. That's why certain, again, O negatives, by the way, and we'll talk about the rhesus factor here in just a second. But type O bloods can receive any, again, you can give type O blood to an A, a B, or an AB. I can only give A blood to an A person. I can only give B blood to a B person. If they are A and B, then I can give them any type of blood at all, either A or B or O. I can give them any of those, okay? I can give an O type, by the way, to a B, or an O type to an A. I can give this to everybody. I cannot give it to, I can give the O type to any of these. A's and B's I can give just to AB, and this guy right here, he's got to have both antigens, or you're going to start getting the reactions that happen with that, okay? And that's my complicated way of me just saying what I just said a second ago. Now, the RH factor is the rhesus factor. Again, the rhesus monkeys, want to go see some, go see out the Silver River. There's still plenty out there. Again, either the person has the factor or they don't have it, okay? And again, what that does is it causes a hemolytic disease to the newborn and can lead to a fatal hemolytic R8 reaction in neonates, especially if they're different from the mom, okay? So they usually have to transfuse the baby when this happens, okay? And again, when you see a transfusion reaction, it's usually they get facial flushing, they start breathing really quick, their sense of dread, hives, chest pain. If you stop and look at this, it kind of looks like an allergic reaction. And by the way, how do we treat it? Number one, stop the transfusion. Number two, again, Lasix to promote diuresis. Number three, Benadryl is actually a very good thing to help, okay? So normal saline, again, in extreme cases, administer your IV epinephrine. Again, Benadryl is another really good drug, another great drug for that, okay? And again, your sensitizing agents, antigens and white blood cells, so you're going to have that. It's going to be attacking everything, that new blood that you just put in. So always stop a blood transfusion before you attempt to treat it, by the way. You don't want to continue to pump what's causing the reaction in there, okay? Again, you can give antipyretics, by the way, Tylenol, acetaminophen, Motrins for the fever. And again, in the event of any transfusion reaction, return all the blood tubing to the bank for analysis. They want to make sure that it's okay. All right. And again, the biggest thing is you may experience signs and symptoms of circulatory overload if you do that when you have a transfusion reaction. And you're going to get a lot of the things that you get with left ventricular failure, the pulmonary edema. You're going to have shortness of breath. You're going to have chest pain, okay? But the hypotension is usually not a problem, okay? Because remember, the blood is actually being added to your system, so you usually don't lose pressure. But boy, it causes all the other headaches with it. All right, we're going to stop there for the A&P part of it, and we'll start on the management on the next video. I will see you guys then.